Thank you so much. We are open to questions. There are mics on each side of the room. And as you ask your question, please, if you can state your name and your affiliation, that would be wonderful. And you can start lining up. Yes, on the right.
Good morning. My name is Erin Rainey, here from the Health Resources and Services Administration. My question's for Dr. Wright. I really was intrigued by an idea you just shared. Perhaps we could be building bridges between healthcare professionals and educators in the sense of providing training and sharing ideas around the solutions to bullying. And given that we're here today because we don't have all the solutions to bullying, I just wondered if you'd wax poetic a little bit about what training objectives you think could be met currently in bringing together those healthcare professionals, their expertise, meeting with educators, and the educators, of course, bringing their own expertise around classroom management, school policies. So I just wanted to hear more about that idea. Thank you.
Good morning, Erin. Good to see you. I have to say that the most sobering part of the last decade journey has been the steep learning curve that so many adults and professionals across the board have with understanding this issue. So I would simply suggest, Erin, that in terms of taking advantage of professional development for educators or for any group, that we really integrate Bullying 101 into a formalized curriculum, whether it's a credentialed process or not, we can discuss, but I really would suggest that for the staff development days, that really what health professionals can contribute and should be able to contribute at the community level is really a very fundamental and basic understanding of what teachers or other folks who are involved in managing children throughout the course of the day are confronted with.
Thank you.
Good morning, Beth Edgerton with HRSA, and thank you, Asha and Joe, for your wonderful presentation. I wanted to build off a theme and maybe a little bit understated, Joe, when you presented about bright futures, and maybe both you and Asha can kind of ponder or brainstorm a little bit about the opportunity we have with the ACA and for children that Bright Futures is looked to as being the preventative services recommendation and reimbursed for children. And as we now expand who's providing health care to children in our communities, your success, Asha, with policy implementation, Joe, your perspective on health care, and what are kind of next steps or possibilities with this national kind of system change?
Well, thanks for that question, Beth. Let me perhaps give an example of where the ACA has provided some opportunity there. Here locally, what we're working on now is a uniform tool for behavioral health screening in the office setting. And right now, the uniform tool is being agreed upon by our local healthcare finance folks who are in charge of the Medicaid program as part of the EPSDT requirement. And I think that opportunity, particularly with Medicaid expansion, is providing perhaps a uniform playing field for evaluation and assessment in the office setting, where all providers and again, this example is expressly addressing the Medicaid population, but that we're using a uniform tool, one that providers are incentivized to use, so that there is compliance, broader compliance, better compliance with those early periodic screening and treatment opportunities. And I don't know if those discussions are happening across the board, across the nation, but I think you're right, Beth, that being able to engage Medicaid directors, and particularly those who are in charge of the reimbursement models, around some level of uniformity about the way that we address or assess children in the office setting does have some promise.
Asha?
I would agree with Dr. Wright's comments, and would just like to underscore some of the steps in terms of getting to that teacher credentialing initiative. So of course there was pushback from teachers, and this is something that was really unique given the timing and the Proposition 63 funding. But another issue is when you're coming to these common measures or common standards, is really, as I highlighted in my talk, getting all of the key stakeholders at the table. And then also acknowledging that those promising practices and model programs that I highlighted and ones that are in the registry are important for setting a starting point and are something that we should encourage other programs to aspire to and get the research and evidence base behind them. But there are a wealth of informal programs like the Safe Passages program I mentioned where the trashmen were acting as informal monitors. And that's something that we can maybe incorporate into a tip sheet or have those kinds of things that maybe aren't as amenable to rigorous research, where you can still get those kernels and those valuable things that the community can offer.
Other questions?
We have a question from the web. Joan asked, what role do you see for school nurses to address bullying prevention at all levels?
I just wanted to address this because it reminded me, I'm in San Francisco middle schools and high schools for a randomized control trial of CBITS. It's a cognitive-based intervention for trauma in schools. And while I was sitting there waiting to meet with one of our stakeholders, a kid came into the office and he said that he obviously had like a black eye. I don't know what had transpired, but they said, do you want to see the school nurse or do you want to just go home? Do you want me to just call your mom? And so then he was sent home. And they explained to me later that they have one school counselor for a massive school. LAUSD is a huge school district, San Francisco is as well, and they have one nurse for this huge school. So they just didn't have the time or the resources. And so this is not to put that school on blast, but it's just to illustrate a larger part of the problem, so that of course teachers and nurses and school counselors are overtasked and under-resourced. So finding a way to bring in members of the community and volunteers to help defray that stress might be one avenue.
And I'll just add that with the advent of the CDC uniform definition, we now have an ability for those who are working at the very granular level, the school nurses are at the tip of the spear, to really be able to, at least from a documentation standpoint, to have some uniformity of terminology, of language around what comes through the health suite. Clearly, the presentation of this issue can come in many forms, and many constitutional symptoms mask themselves as the consequences of bully victimization, and I think certainly along the lines of training and education, school nurses are I agree, there's a bandwidth issue, but certainly in terms of access to the problem, they are very much a part of the provider milieu that I was talking about just a few moments ago.
Good morning. My name is Suzanne Greenfield, and I'm the director of a citywide bullying prevention program here in Washington, D.C. And I would like to say we are not just in schools. We are in our Parks and Recs, our after-school programs. In fact, Parks and Recs is well represented, actually, in the audience here today. Thank you, my colleagues here. And we really would I'd love to hear, first of all, thank you, Dr. Wright. Obviously, from your letter, you can see he was instrumental in helping us pass a policy and a law, but more importantly, focusing it on the prevention model of what we can do. Dr. Weber, do you have any other examples of parent engagement and building from the community, since we have that opportunity, but there aren't a lot of places to look to see how that's done and done well, because we really feel like that's an important piece of the work we need to be doing.
So thank you for your question. That's a great point about how to engage parents. For bio parents or adoptive parents that are in the home, there is also the issue of bandwidth and time if people are working 2 jobs. But what I've seen in the projects I've worked in particular are that you're trying to meet the individual where they are. So instead of having them come to a university setting or to a location, having events in the community or doing things where you provide bus fare or taxi fare or meal, something where it's, like I said earlier, return on investment, where you talk about, okay, well, what are your concerns, and can I provide this data back to you in a meaningful way that makes sense so that you want to invest your time and energy.
Any other question from the web? Okay. So I would like to, the way that we do prevention tend to be very sort of distinct issue-specific: pregnancy prevention, sexual transmitted prevention, HIV, bullying prevention. Do you think, and also the funding tend to be like that, very separate, very categorical. Do you think that there is a need to continue to do that very specific, issue-specific prevention, or should we think about a more universal prevention that actually address all of these issues simultaneously? So I would love to hear your thoughts about that.
I'll just say I couldn't agree more. That's what I really liked about the work of the Harborview study, that independent of issue, the stressing those kinds of behaviors in the home, apply a universal prevention model. And the subject of analysis happened to be bullying for that study, but the promotion of those kinds of activities for preschool children, and the other piece that was important that I perhaps didn't stress enough was that that work stressed primary prevention. So these are preschool kids before they enter into school, and really speaks about prevention, not secondary prevention, not looking at after the issue is presented, but beforehand. But I couldn't agree more, Dr. Diaz, that I think that a universal approach, and that's why it's sometimes challenging from a research perspective, to tease out bullying in the context of other behaviors that children experience. So I agree completely.
Thank you. Ash?
Yeah, I would also agree, and that goes for, from an equifinality and multifinality perspective, at the onset and at outcomes. So having calls for funding schemes that maybe address universal early prevention issues, like focusing on kindness or compassion and things that cut across the board. And then, of course, we know about co-occurring disorders, so it would be ideal if programs didn't just target one specific outcome, and funding schemes as well.
Yes, on the left.
Yes, I'm Nina Fredlund from Texas Women's University, and part of the planning committee. So I'm very honored to be asked to be here and to have nurses at the table. I'm a nurse educator, a nurse researcher, and I've been working with middle schoolers to look at nurturing healthy development and healthy relationships. And also we're following 300 women that have been abused, and 300 of their children in a 7-year prospective study. So I would like to highlight the importance of collaborations, not only with school nurses, but with nurses across the board, nurse practitioners, and also to ask how could we collaborate with school psychologists, school social workers, and just make sure that everyone is at the table, because we do not have enough healthcare providers or practitioners to handle all of the mental health services that are needed. So I would just like to ask your thoughts on going forward to provide some of these services.
Well, I think there are some sort of fundamental systemic opportunities that rest within the school setting, and I'll just cite one. If I've already mentioned the fact that we have an opportunity for all of us to be singing off of the same song sheet in terms of definition, and I think it's critically important from a documentation standpoint, and particularly if documentation lived as part of an electronic health record, where the practitioners, regardless of setting, are now talking about the issue using the same language. And again, it sounds fundamental, elementary, but it's almost the contrary is almost like everyone feeling a different part of the elephant and not really being on the same page. And that's something that I've experienced as a practitioner in interfacing with those in the school setting, or seeing kids for my practice in the emergency department, trying to work with the primary care setting. And so I think being able to have uniform language is really, really, really important. And it speaks to policy as well. Suzanne talked a moment ago about what's going on here locally, and certainly part of the challenge was to make sure that the public school system is speaking the same language as charter school system is speaking the same language as Park and Rec is speaking the same language as the healthcare community, and that we're all on the same page. And I'm not sure, I wasn't here yesterday to hear the presentations, but I trust that the value of the uniform definition is something that has been part of the dialogue here the last 2 days.
Thank you. Right.
Thank you. I'm Ken Dodge from Duke University. I have a question for Dr. Wright. I applaud your goals and hope that all of what you recommend can be implemented. I have a two-part question. First part is, I wonder how practical it is for the average pediatrician to take the time to get to know a child and to talk with the child about bullying and victimization, given how little a pediatrician is reimbursed for an office visit, given the other areas that we want pediatricians to address, behaviorally even, from wearing bike helmets and seat belts to eating nutritious foods and getting exercise and all of that sort of thing. So I wonder how practical it is. Then the second part of the question is, have you considered building in the systematic collection of information from schools, school teachers, preschools, elementary schools, middle schools, about the child's social adjustment, social status, social behavior that the pediatrician might receive, annually before the annual pediatric exam or something like that, as a quicker and more in-depth way of collecting information about the child's social context?
Well, I agree with you from a very pragmatic perspective about the challenges of bandwidth in the office setting. You're absolutely correct, and which is why I think what needs to be stressed is the incorporation of this issue as part of a longitudinal approach. I mean, I think it's impractical to suggest that baking bullying in as a episodic issue-driven approach to the longitudinal care of a child is realistic, given all of the other pressures on the office-based practitioner. However, and one of the misnomers that you may have noticed in my presentation, I talked about this in the context of middle childhood, yet the one piece of evidence that I presented really spoke about the preschool child. And I think the only opportunity that really makes sense is for this to be baked in from the beginning, and to be baked in every single visit in a global prevention strategy, not focused expressly on bullying, but we have the suggestion that attentive anticipatory guidance can build protection against bullying behavior. And mind you, the work of the Harborview group was protective for a child being a victim or a bully, so being involved in the behavior altogether. Now, the other issue with regard to the building of a database is really what you're suggesting. That would be wonderful. Part of the challenge has been, obviously, until literally this moment, we have not had, and I've harped on this throughout the morning, a real uniform set of definitions to build a database around. Now, Dr. Limber and colleagues at Clemson have, for the last, is it 3 years, Catherine, have had the database that has been a national database, a longitudinal database, that I do think health providers need to be contributors to. How that is to be accomplished will need a deeper conversation, but I agree. Schools, healthcare providers all need to be contributing data into that set, and whether it can do, as you say, which is really provide a granular picture for someone in an office-based setting, it's possible, but until we get the information in, it'll be a challenge to figure out how to best use it. But thank you.
I would like just to add a little bit to that, that I think though, you know, I'm also a clinician, and I have been working with youth for 30 years, and I think that the environment, when people come to see their provider, they just feel almost like if that's a sacred space, and that is confidential. So they are willing, the young people are willing, if you ask them directly, to really share their entire life. But doesn't have to be the physician doing this questioning and interaction. You know, we have many different members of the team, the nurses, the health educators, the social workers. But I think that space somehow make it much more conducive to get this type of history. And I think we should really take advantage of that to really, we will know the life of the kids, you know, what they really struggle with, what's really in their soul. They are willing to put it out there in that type of environment. And I had not necessarily seen that in different type of environments. Yes.
Good afternoon. I don't know what time it is. Good morning. My name is Natasha Hearing. I'm with the District of Columbia Department of Parks and Recreation. So from a Parks and Recreation perspective, my question is, how can we make the most impact in a way that's not so regimented? So my question stems from, in the morning, kids leave home, which is typically a regimented situation. They go to school, it's regimented. After school, they go to recreation or after centers, where typically in their mind they're ready to play before they go home to the regimented setup. So in order for them to be able to gain something, especially I think Dr. Goldweber, you mentioned before, between the hours of 3 and 5 is when bullying takes place the most, where they're at recreation centers during this time frame. So how can we as recreation professionals provide the most impactful anti-bullying message to them during a time where they really don't want to be regimented, they want to play, they want to relax before they go back home to being regimented again?
That's a great question. And getting information to folks at Parks and Rec and people who are overseeing the children would be helpful. And again, uniform information. We've heard throughout the course of this summit, this idea of just say no to bullying or we don't do that might not always work. So providing Parks and Rec with proper guidelines for how to address bullying, but in a way that doesn't feel regimented. So allowing kids to still play, but to intervene when appropriate, to monitor, but not in an overbearing way that makes it seem regimented would be a very inadequate answer for a very complicated problem. But in that informal play, there can be opportunities and learning opportunities that arise. And also, I don't know what the structure is, but during that setting, there can be things injected into existing play that are, again, learning opportunities.
Thank you. Joe, would you like to add?
Yeah, I mean, I would agree. We really are sometimes accused of creating a nanny state environment for our kids with regard to the regimen that you talked about, and as we, as an organized medicine, develop policy to drive the way that that care is provided, really need to incorporate the notion that kids do want to be kids, and that play does provide opportunity to and safe play does provide opportunity to teach. So, but again, what I think about during those hours is the opportunity for Park and Rec to leverage healthcare providers to be a part of that. It requires collaboration. Both you and I are here in town, and now that we're having this conversation, I mean, maybe there's something we can incorporate.
Yes, that was actually the second part of my question was to, there's always an ulterior motive, but just to know whether or not, and it could actually be occurring now, I just may not be aware of it, that Parks and Rec professionals are brought to the table when we talk about from a clinical standpoint, which you all provide an excellent standpoint on, but from the Parks and Rec perspective, if we could all be brought to the table. So we'll be in touch, Dr. Wright. Thank you.
Since I see no other questions, I would love for you to join me in thanking our panelists.